So we can get started. Thank you all for coming to the Teach Yourself session today. Health Policy 101, what we have, why it's bad, and how to fix it. So my name is Macon Fessenden. I'm going to be presenting today. So this is me. I'm from New York. I work in the ED at UC Health. Founding member of the union, UCHWU. Completed, it's like the coolest fact about me was that I completed the Colorado Trail two summers ago while working full time. And then I just want to let you guys know, I guess we'll like have a stutter and it comes out a little bit more when I get nervous. So just bear with me if that happens. All right. So all right. So I'm going to get started by just kind of talking a little bit about health insurance. So we pay into like a big pool of money, either through taxes, that's for Medicare and Medicaid, or premiums, which is for private insurance, that then gets distributed to those who are sick. So people tend to pay more than their share when they're young to subsidize the cost of those who are older and sicker. But then we get those benefits when we age or become sick. And this is a model for both private and public health insurance. Premiums are calculated by complicated algorithms that try and determine your likelihood of becoming sick that year. They take into account age, sex, smoking status, where you live, etc. All that good stuff you get asked when it's time to sign up for insurance through your job. That's what I do. So before we dive into what the American healthcare system looks like, I do want to go over some terms that's going to kind of help everyone understand some of the policies that we'll be talking about. So the first one is universal healthcare. This is the concept that everyone in a country has access to affordable healthcare. It can be free, it can be, or it can be free for all, like in Canada or Britain, or through a mix of systems like what America and Germany has. But this simply states that that everyone has coverage. So when you hear the term, we're looking for universal health care, it's saying that everyone has coverage, not everyone has free coverage. Uninsured versus underinsured. So an uninsured person is someone who has no health insurance, and underinsured are those who technically have insurance but still have lots of out-of-pocket costs in relation to their income. Sorry, there's still people trickling here. Okay. So next term is I want to make a distinction between these two. So a universal versus means tested program. This is like an age-old debate that's just as lively as it is, as it's been for decades. So universal programs benefit everyone regardless of need. Think like public schools. They tend to be more expensive and give out unnecessary benefits to rich people, but they're more politically durable because everyone feels that they have a stake in the program. Means tested programs are targeted at a certain group of people, usually income level. I think this is like food stamps. They're more efficient, but they're always subject to policy fights. We'll get more into the difference between these later. So equity versus equality. Equality is making sure that everyone gets the same resources or opportunities. Equity is allocating resources or opportunities in a way that acknowledges that people have different struggles and needs. So there's the classic graphic of the three different sized kids standing at the fence, and equality is giving them all the same box to see over the fence, and equity is giving them the box that's tailored to their size to make sure they can see over the fence. Federalism. Federalism is a type of government where power is shared between different levels. So it's usually like a central government and then different types of regional governments like states, cities, provinces, whatever. This is a foundational American ideal and comes into play a lot when we're discussing policies that improve people's lives like healthcare. Administrative burden is a term that was coined in a book by two political scientists. this describes when a policy or program is difficult to navigate with the purpose of making it less generous. So a great example that came up last year was unemployment benefits in some states, especially in Florida. They're understaffed, there's a lot of complicated paperwork, and then they have this really outdated computer program that they've been using. And this is all to make unemployment insurance less generous and difficult to access. It's not necessarily like, oh, we don't have the money for it. We want to make all these hoops to jump over so that people don't sign up for it. So single payer versus nationalized health system. This is an important distinction that I think gets kind of mixed up a lot. So a single payer system like Canada means that the government is like the insurer. They pay all the costs, and the actual providers of the healthcare, like hospitals, doctors' offices, physical therapists, they are like a mix of public and private entities that like we kind of like have here in America. But a nationalized health system like England is when the entire health system is owned and paid for by the federal government. So public option is a government-funded Medicare-like healthcare coverage. So anyone can buy into this. It's in addition an alternative to private insurance. We're going to get more into this later as well. Healthcare rationing. So every health system needs a rationing principle. In America, it's costs. In Canada, it's wait times. In Britain, it's a centralized government board that tells you whether or not they're going to pay for a procedure or medication, something like that. Some we're going to get into a little bit. It's something that's like not really that well understood among I think people don't really think about healthcare rationing when they're trying to like devise a perfect system. And finally, market failure. So this is when a sector of the economy's market incentives do not align with social good, or when markets inefficiently distribute goods. Market failures require governmental intervention, and healthcare is the classic example of a market failure. All right, so, by the way, if you guys have questions, you can just drop them in the chat. I do have someone who's going to be monitoring and letting me know. My lovely assistant who's right behind me. So what we have, so America has a very fractured, multi-layered healthcare system. So Medicare and Medicaid are a single payer model, like in Canada, where you pay taxes to the government, and then they just pay whoever, the hospital and doctor's office you're going to. The VA and IHS, which is the actual name of the place. I know it's not the right term at all, but these are nationalized health systems that, like the UK, where the doctors are paid by the government, the hospitals are paid by the government, are owned by the government, and the government is also the payer of those. So, if you're a veteran, you can get all your free healthcare done in a VA hospital, which we have on the Andrews campus, and I'm sure if anyone has worked with this population in a non-VA setting, it's like they get transferred over there as soon as possible. They really don't want to. They don't want their patients being taken care of at any other place. And then finally, there's a mix of private health insurers that are paid directly by their customers via premiums for health insurance, and then those health insurance companies pay the providers. So just getting to the history about Medicare and Medicaid. President Roosevelt signed into law the Social Security Act in 1935, which had no provisions for healthcare, but it was something that he wanted to do. But 10 years later, President Truman called for the creation of a national health insurance fund. But his vision wouldn't come until LBJ signed a sweeping set of amendments to the Social Security Act in 1965, creating Medicare and Medicaid. Under his vision, known as the Great Society, and this is just like a set of anti-poverty amendments and laws that were passed under LBJ. The goal was to take care of our most vulnerable populations, elderly people who could no longer work, and poor families. So these programs have gone through many changes over time, but the core value at its heart remained. So a little kind of fun fact about President Truman who was the one who called for the creation of a national health insurance fund and tried to, but failed. He was actually the first recipient of, like, the first enrollee in Medicare. They like rolled that out, which I thought was pretty cool. So these are both administered by the Centers for Medicare and Medicaid, or CMS, which that's an acronym I'm going to be using. All right, so Medicare. This has gone through many changes over time, but it's endured as the most popular programs in the country. Every American citizen is eligible for Medicare when they hit 65. The process is simple and easy to navigate, so there's little to no administrative burden here. If you're on dialysis or you have ALS, which I'm going to talk about in a second, but you're also eligible for Medicare with no strings attached. You just sign up. So the government has for a kidney failure, the government should have a very strong incentive to get people transplants. But if you've ever worked in the transplant world, you know that there's some barriers to that. But so the Trump administration actually added ALS at the end of last year to just kind of fray the costs of this horrible disease. I think it's not really any different than any other disease, like progressive demyelinating disease that just gets, you get weaker and weaker over time. But it is definitely a step in the right direction for allowing the people who take care of people who have ALS, that they don't have to worry about working because to get health insurance. They can just stay home and take care of their other loved one. It's an interesting thing that the Trump administration did, because it's a model for like what our society could look like if you just applied the ALS standard to like every other disease that like or just aging. So I don't know. And then also, if you have Social Security disability insurance if you're on that for 2 years, you can qualify for Medicare. All right, so this is super dry. I'm just going to quickly go through this, but this is there are 4 parts of Medicare. There's Part A, which is hospital coverage. So this is free, and everyone who's eligible gets it automatically. So it's obviously this covers care inside of a hospital. And there's some complicated things like what technically is inside of a hospital versus like a long-term care center, blah, blah, but like just at its base, hospital coverage. Part B is doctor's office coverage. This is also required, and it costs a small premium. I'm going to skip ahead to D. Part D is prescription drug coverage. This was added in 2006 by the Bush administration. It's optional. It cost a small premium. It was passed because drug prices were getting out of control. Apparently there was a point in time where you could pay for prescription drugs out of your out of pocket, which seems wild. Oh, Helena has a question. Yeah, that's a good. I did not dive into this too much when I was doing this research. Helena asks, was the push to get ALS added because of lobbying and grassroots efforts? I imagine it was. There's just in the past 10 years, I guess, as I'm sure we're all aware with the Ice Bucket Challenge, it's just like there's been a lot of like activism work around ALS. So I mean, I don't know how much the Trump administration was receptive to like health advocacy groups, but it worked. So all right, and then Part C is Medicare Advantage. This is like super complicated. I'm not even really sure I fully understand it, but this was passed to give to so people can sign up for Medicare Advantage plan through a private insurance company, and then that private insurance company manages their care, which is complicated. Also, nothing changes about who they can go to, how much things are, like there's no premium or anything. It's just like they thought. Whoever passed this thought that the federal government couldn't handle it as well as the as the private market. That's a value statement. That's all I'll say about that. But so Medicare pays the insurer a fee to completely handle that person's care. Yeah. All right. So remember back to our slide on universal versus means tested programs. Is Medicare, you just dropped this in the chat. Do you guys think Medicare is universal or means tested? Yeah. Yeah, Helen, good save. Yeah, it's universal. So it's like, it's a little, there's nothing really is truly universal. Like public schools are true. Like I can't go to, like I'm 29, I can't go back to high school if I wanted to. So nothing is truly universal, but that's like kind of a dumb distinction. The reason I'm bringing that up is because yes, like there are eligibility requirements for Medicare, but once you hit those eligibility requirements, so like you don't need to do anything to be eligible for Medicare except for just get old. So that's why we think of it as a universal program. All right, so Medicaid covers a fifth of all Americans, about 77 million people, and is the primary source of health coverage for those who do not otherwise have access to affordable health insurance. Medicaid tailors its eligibility to a certain income level. It's usually a percentage of the federal poverty line, so it's 100% or 138% or 250, whatever. And this is an entitlement program, which means that everyone who qualifies for it receives it, as opposed to like Section 8 housing vouchers, which is not an entitlement program. So there are hundreds of thousands, maybe millions of families throughout the country who are eligible for Section 8 housing, but who are just sitting on waiting lists. Very frustrating. But that's something that the Biden administration is actually going to try and fix. But this is an entitlement program. So if you hit that level of the federal poverty line, you're automatically eligible for it. Now, enrolling in it is a whole other story. But yeah, so Medicaid is structured as a federal-state partnership. So the Centers for Medicaid and Medicare Services sets criteria that every state's program must meet. But otherwise, the state has flexibility to choose payment models, eligible populations, and covered services. The costs are split between the state and the federal government with an optional expansion under the ACA, where states would receive hundreds of millions of dollars to expand the eligibility requirements to cover more people. So this is generally they would make it more generous. So instead of 67% of the poverty line, they'd move it up to like 138% of the poverty line. But so this money was free, so there's no matching requirement. But due to political reasons, 12 states have chosen not to accept this free money. So there's 4 million people in those states who are without Medicaid coverage who would otherwise be eligible. So Medicaid expansion is extremely popular and has been a key point in a number of Democratic victories, state houses. It's something that they like to run on. Most notably Virginia in 2017, if you guys remember that, back in that race, it was the first real election after the Trump election. So there was just like a lot of what's the word? People were very excited about it. And what they ran on, one of the things they ran on was Medicaid expansion, because Virginia hadn't expanded. Virginia used to be a very red state, and now, or I guess it used to be a purple state. And then they, so the whole country was following this race. They took the governorship, and in 2017 they took one of the houses. I don't remember which one, but they were able to, with the help of a couple defectors from the Republicans, they were able to pass Medicaid expansion. Virginia is a big state, so that like was able to cover like hundreds of thousands of more people. But also it's been expanded via ballot measure in 7 states. So and it's actually never lost a ballot measure for the initial expansion in any state in the country. So there's not every state. If you guys are from Colorado, you might not know this, but not every state can do ballot measures. New York doesn't do ballot measures. So, but there's 2 states right now, Florida and Mississippi, where Medicaid expansion will be on the ballot in 2022. So, if you guys are interested in some grassroots stuff, that would be awesome. Florida is huge state. It's the second biggest state after Texas that doesn't have Medicaid expansion. So it would be huge if I think it's like 1.3 million people could get free, free eligibility, free healthcare. Sorry, would be eligible for free healthcare if Florida alone expanded its Medicaid. Oh yeah, thank you. Yeah, so thanks, Joe. This was like it was a big fight. So the question from Joanna is, why would a state not want to expand Medicaid? It seemed like a win-win. So this was just like a big fight in the ACA. It was actually taken to the Supreme Court, and in a fascinating exchange between John Roberts, who's the Chief Justice, and a lot of and the rest of the so John Roberts, I read about this in like his biography, which is actually really interesting if anyone is interested in John Roberts. Very interesting guy. So John Roberts did not want to scrap the whole ACA, so he made a deal with everyone, which is just like you're supposed to be a stoic, sober, interpreter of the law, and there's like only supposed to be one interpretation, and he's like making deals with people he's just like a common politician. It's pretty gross, but he made a deal where he would leave so the whole ACA got taken up to the Supreme Court, and he made a deal that said he would leave the most of the ACA in place, but struck down the Medicaid. It used to be, this is the key. It used to be mandated. So there was a mandate that said you have to take this money and you have to set up new eligibility requirements. And then, that mandate got struck down. So it was no longer mandatory, but the money was still free. It was everything else about the program was the same. But and just like a show, just like gross, bald-faced, polarization politics BS. I think it was initially, I think like 24 states decided to not. It's less than 24, whatever, 20 maybe. Those states, all red states, all run by Republicans, had decided not to expand Medicaid, and people have died because of this. I don't know, I know people who have, I've taken care of people who have just aren't eligible for Medicaid because they fall in that gap, and they just they weren't able to get life-saving care, or they weren't able to catch something earlier because they couldn't afford a doctor. It's very frustrating. So yeah, all right. Okay, so is Medicaid universal or means tested? Drop your answer in the chat. And why? Yeah, so it's means tested. Peter says, what is Denver Health Medicaid? Is it like Part C but for Medicaid? I have no idea, Peter. That's a great question. We get Denver Health Medicaid patients in our ED, and we like to send them over to you guys. I'm not sure what Denver Health Medicaid is exactly. I wonder if Colorado, I'm going to talk about Colorado Medicaid in the next slide, actually, but I wonder if Colorado, or not the next slide, the slide after this, has made a deal with Denver Health, or if it's like a city thing. That's a great question. Okay. We'll get an answer. Yeah, no, I know it's very interesting. So I can't wait to hear why. All right, so these are the 12 states that are not expanded Medicaid. This map is a little outdated, so there are 14 states on here, but 20 at the end of 2020, Missouri and Oklahoma passed ballot measures to expand Medicaid, and then so those programs will get implemented on July 1st. Like, this is what I'm saying, guys. Like, Missouri and Oklahoma, those, like, in the same ballot, people like did Josh Hawley win 2020? No, not Josh Hawley, but awful people have been elected, and Medicaid expansion passes. Utah expanded their Medicaid on a ballot measure. Like, these are extremely conservative places, but when you're talking about actually helping people, like your, like, where you see yourself on a left-right spectrum, just like kind of goes out the window. It's just it's so much less important. All right, so this is talking about Health First Colorado. If you sign up for Health First Colorado, you will be happy like these people. So Colorado is one of 39 states in DC to expand Medicaid under the ACA. Its Medicaid program is called Health First Colorado, and it covers 1.4 million people. Sorry, I'm just reading Joanna's thing. As of September 2020. So remember, administrative burden. So we make choices about the ease of navigating our governmental bureaucracy, and Health First Colorado is extremely easy to navigate. So my girlfriend Joanna, she works in homeless services. So she would sign up a client with only his social security number. And did he have a social security card? Didn't even have a social security card, just his number and his self-reported income, which was 0. So Health First Colorado will also back pay all health costs up to 90 days. So if I sign up today and I was in the hospital 2 months ago, it'll pay for that. If you have any questions about signing up patients for Health First Colorado for Medicaid, you can talk to your case managers. We do it a lot in the emergency department. I think it's an incredible service. And if you can get people access to just like free health insurance, and just like a lot of like poverty programs, there's this misconception that once you get on a poverty program, you're in it for decades, and most people kind of slide in and out. And Medicaid might be one of those things. Like someone might present to the ED and they're just like, they just lost their job a week ago or whatever. You know, it's the pandemic, and then they just don't have health insurance. But you know, and then we get the Medicaid, and they have Medicaid for 3 months, and then they get a job again, and then they get health insurance. And so it's like this is something that we should really be pushing a lot. And it's free, and insured people have better health outcomes, which is cheaper for everybody. So if there's anyone out there who is worried about taxpayer dollars going to anyone who walks into the emergency department, or whatever, like anyone who needs care, if you have health insurance and if you have Medicaid, then you just tend to have better health outcomes. There's this great natural study that was done in Oregon. It was a natural study because they had, this was before the ACA expansion, but they had expanded their Medicaid benefits, but only to, it was like on a lottery system. So if you applied, so you had to be eligible to apply, and then so everyone who applied was eligible, right? So then there's only, there's 10,000 people and only 1,000 people get coverage. And then they followed those people versus the control group over time, and their health outcomes were better. Even though they had insurance, they didn't have to use the health system as much because they were healthier. They had better education outcomes. They had better income potential. It's like it's all them and their kids, I should say. Yeah, I don't know. We can go, that's a whole other presentation, like the social determinants of health, that I would love to do one day, but yeah, so, oh, cool. Yes, I will. I'm getting to that. All right, so the last tier of what we have is employer-sponsored health insurance. So most Americans, like 55% in 2017, get their health insurance through their employer. So the employer makes a contract with a private health insurance company. So like UC Health will make a contract with Aetna, or I don't even know who their insurer is, but and then the premium costs are split between the employer and the employee. So I get whatever, $25 a paycheck taken out for health insurance, and UC Health pays the rest, which is like a lot. So many offer multiple plans at varying cost. So you can get the good plan, or like the not so generous plan, the high deductible plan. Every company with more than 50 employers must offer health insurance. So that's that was a mandate that was set by the Affordable Care Act. This works really well for people who are employed. So like, it's great for me because I have a job, and that's great. But I like my job, so it works really good for me. But if you lose your job, you lose your insurance. So a lot of people who are stuck in jobs that they don't like, simply because they are afraid of losing their health insurance. So so it's called job lock. So like tying benefits to a job keeps people, which is like, I mean, that is what the employers want. Like they want people staying at their jobs. But I have a friend who she is like self-employed, and he does, like, his passion is not what his job is, which is he drives for Quest Diagnostics. He does a lot of stuff with woodworking, and he does day trading, whatever, blah blah blah. But he had to get health insurance, but he had to get a job driving for Quest. He's like a 55-year-old man who is like, like nearing retirement age, and he has to like get this new job because they need health insurance. And it's just like, he hates his job, but it's just like they need health insurance because they're in their 50s. So and also because more profitable companies can offer better health insurance to attract better employees. This creates a real big equity issue, where more well-compensated employees are also the ones with better health insurance and better benefits. And it's like, anything about the social determinants of health, that like people with lower incomes, or people who aren't employed by these big companies, it tends to translate to worse health. Oh, I'm sorry, there is one more thing. Obamacare, ACA. So another type of private insurance are individual plans brought on the marketplace or exchanges, which are created under the Affordable Care Act, or Obamacare. These exchanges are for those who do not qualify for government-issued health insurance and do not get insurance through their employer. Like Medicaid, each state has their own program. So these are known as an exchange or the marketplace, and they assist people in purchasing individual health insurance plans. So they're tiered from bronze to platinum, and as they go up in tier, obviously they get more expensive, but they get better, they get more generous. But each tier is subsidized, or the premiums are subsidized based on your income. So the more you make, the more each plan will cost, and that's all within those tiers. So if you're like Jeff Bezos can buy a bronze plan, it's going to be whatever. It's going to be more money than if I buy a bronze plan, or if someone who's making less money than me by the bronze plan, etc. All right, so drop this in the chat. ACA, is it means tested or universal? Just throw your guesses out. So yeah, I think both. It's like anyone can sign up for it. So it's available to everyone, but the premiums are subsidized on a sliding scale based on income. So yeah, both is good. I don't think that anyone actually talks about the exchanges in this way, but I thought that I wanted to just bring this up. All right, finally, why it's bad. Um, so, um, so obviously we have a big problem with our health insure or our health model in America, because we have like, I think it's 30 million uninsured. That might be high. I don't know, but we have a lot of uninsured people. So one of the reasons why it's bad is because it has nothing to do with America. Like, healthcare has a market failure in every setting, but America has not um, treated it very well. So markets are very good at setting the highest price that people will pay for goods and services. But when the good is life-threatening care or life-saving care or your own health, the price you pay theoretically has no ceiling. So, sorry, the price you are willing to pay theoretically has no ceiling. And then you add in like vast information asymmetries. This is when the provider of a good has more information than the consumer. A lot of moral hazard and no price transparency. This creates a lot of perverse incentives and bad outcomes when we have a for-profit healthcare industry and a private for-profit healthcare industry. Market failures like this require governmental intervention. We're just not invested at all in solving these problems. But the market has failed in another sense. So I was kind of getting into this earlier, but there should be an economic incentive to invest heavily in the health of the members of our society. Since every dollar spent on health reaps many times that in quality of life indicators. So which increase wealth individually and collectively. So we just are when we're a healthier society, we're a wealthier society. But there are many reasons why that doesn't happen, including like in-group biases, time preferences where we care more about the present costs than future benefits, lack of compassion, prejudice, just all these horrible things that cause us to not invest in the health of a society as a collective. And I mean, this presentation is for a union, right? And unions are they rely on collective power and solving collective action problems. And governments, one thing governments are good at is the reason why governments exist is to solve collective action problems. And I'm going to get into this later in another bullet, but so we all know about that, like healthcare costs are rising. So between 1970 and 2019, the share of GDP that healthcare costs represent increased from 7% to 17%. So this is not like an actual number. It's nothing to do with inflation, blah, blah. It's literally like we used to spend 7% of all our money, and now we spend 17% of all our money on healthcare. There's many reasons for this, including moral hazard, I didn't explain that earlier. This is the idea that people engage in riskier behavior. They're shielded from its costs. This is like the classic problem with health insurance. Pharmaceutical and medical device innovations, corporatization of healthcare, high administration costs. That America is not a very healthy country, is causing high costs, blah, blah, all that stuff. So this problem itself could be like an entire college course, and but it's one of the most complicated problems that we face as a country, like as a whole, not just in healthcare. Like healthcare costs are going to dwarf our economy soon. So it's really complicated. There's a lot of stakeholders that have very large monetary incentive to continue allowing healthcare costs to rise. There's no easy solution. If you guys are interested, I mean, I'll talk about recommended like further media consumption later, but I've got some great podcasts if you guys are interested in this. So this is what I was getting back to what I was talking about earlier. So America's a very individualist society. We believe that each person should only take care of themselves and their families. And if everyone does that, the world will be great, good, and perfect. But this worldview is actually the exact opposite of how insurance works, because you need everyone to pay in when you're healthy, so that you can reap the benefits of you paying in, month after month, year after year when you're actually sick. Because nobody can afford to go to the hospital if it's going to cost them $10,000 once out of pocket. But if you have health insurance and you've just been paying it slowly over time, blah blah. So so this worldview also causes well-off people to late entry. So it's actually the opposite of, sorry. So this worldview causes well-off people to assume that the less fortunate deserve what is happening to them because they think, oh, I'm fine and I did X, Y, and Z. All this theory person needs to do is X, Y, and Z, and they'll get to the position I'm in. But the right to health care is among the UN Declaration of Human Rights. And even if you do hold that belief, this is, people deserve to have healthcare. It should not be dependent on financial or social status. If we want to create a just society in which people thrive, we have to have a stake in their health outcomes. We can't have people who are sick. We can't just leave them and just let them rot, because we all should be invested in this. It's not just that I want to be healthier because it's going to be better for me. I want all of you guys to be healthier because it's going to be better for me, because I'm going to live in a healthier, more just society. And finally, so federalism causes lots of inequities. So federalism allows states to act as laboratories of democracy. This is a term that gets thrown around all the time, and allows them to tailor programs to their actual constituencies, which sounds great. But the dark side of federalism is very sinister, because every state has different standards for the programs we talked about and a lot of other programs. The state you live in has a lot to do with whether or not you're going to receive quality health insurance. The unfairness of this, in my opinion, far outstrips the benefits we get from a federalism model for assistance programs. The opposite of a federalism model, so Medicaid is set up as a federalism model. So each state is allowed to run their own programs, and Medicare is just not. It's centrally administered by the federal government. The states don't come into it at all. But so federalism has its place, but I think that when it comes to health coverage, every American deserves to be treated the same, regardless of where you live. That's such a weird thing. It's not like oh, I live in a good neighborhood. It's like, if I live in Florida, I'm going to be less. And Florida is huge, and there's a lot of different places to live in Florida, but it doesn't matter where in Florida you live. If you are poor in Florida, there's a good chance you're going to fall into that gap of between being able to afford health insurance / getting it from a job and qualifying for their less generous Medicaid program. All right, so how to fix it. So we discussed some of the reasons why the American healthcare system is broken, and here are some ways to fix it. Yeah. So the benefit, so are you talking about Medicaid, what's happening now? Yeah. So Medicaid, so each state has their different, so this is the whole thought process behind it. So it's whole justification of federalism is that each state has their own challenges, they have their own types of people, and that state knows the members of their state a lot more than the federal government does. So so that's one justification, is that each state can tailor its programs to the people who live in the state. So if and these things get very complicated, what happens with Medicaid, what you get when you get Medicaid, it's very complicated, and I don't know everything about it. But Colorado has a bunch of people, Coloradans are different than North Carolinians, are different than Oregonian or whatever. Oregoners. So like that's the justification. So that's one. The other is that smaller programs are run better. That's the justification. I don't necessarily that I'm not saying that's that I believe that, but the concept is that a big program is harder to like it's less nimble. There's more bureaucracy, there's more red tape, there's more veto points, etc. So, all right. So we're talking about proposals. So this is talking about Medicare for All first. So this is Medicare for All, or a single payer health system, is a nationalized health insurance plan. Okay. So in other words, the government replaces the insurance companies. It does not replace the healthcare providers. And then the government pays for everyone's healthcare. The government does not take control of all the hospitals and doctors' offices. Medicare for All would mostly solve all of the problems that we talked about and all the failures we spoke about. But by nationalizing the payer, we eliminate the need for that entity to make a profit because they're not owned by stakeholders or by shareholders. I mean, they're like the government does not need to make a profit. I'm gonna make a banner about that because that is because there are many people who don't believe that. But the government is in the business of spending the money that taxpayers pay it in order to make their lives better. It does not need to make a profit. Thereby eliminating much of the market failures that plague our current system. Medicare for All would reduce costs by instating something called single payer rate setting. So right now, Medicare, they insure a huge chunk of the population. So they're able to negotiate with hospitals and keep costs down for their customers. So sign out, they are not allowed to negotiate with pharmaceutical companies, so they cannot negotiate drug prices. I don't know why. I mean, I do know why, because the pharmaceutical companies have very powerful lobbyists. But I don't know why that was ever a thing, why that ever even was thought about. Like right now, I'm sure that if it were flipped, the American Medical Association, is that whoever, like the big hospital lobby, they, I'm sure, would fight tooth and nail to making sure that that they couldn't negotiate, that Medicare couldn't negotiate with hospitals, but you know, it's already in place, and I just don't know why the prescription drug thing. It doesn't make any sense, but that is something that does get thrown around when in discussions on how to lower healthcare costs. Medicare also, it allows that type of like single payer rate setting that Medicare does right now. It sets a benchmark for what things should cost, and then health insurance companies can negotiate based off that benchmark. But anyway, so if Medicare insured all Americans, they would have even more power to do this. So they could keep costs down even more because the hospital and doctor's office can't afford to just not take Medicare. Even, I mean, they can't afford to do it now, and they would even or not be able to afford it if everyone was insured by Medicare, or like the vast majority with whatever, like little private health insurance companies here and there. Critics of Medicare for All say that it would be too expensive, that it would require increase in taxes to the middle class, and the government can never do anything better than the private sector. So that's what critics would say. All right, so the public option, or as Secretary Buttigieg would call it, Medicare for All who want it, is a proposal that's been kicking around for a while. I know it's being tossed around in the Obamacare fight back in 2008, 2009. Joe Lieberman killed it, so fuck him. He's awful. But he's a former Democrat. I think he might have switched parties, but he was a Connecticut Democrat who he's the Joe Manchin of 2009. So everything needed to go through Joe Lieberman. So the only way that they could pass the ACA was if they got rid of the public option. Yeah, he did switch. Yeah. So this has been revived over the years. It's been in a plank of the Democratic Party platform in the past two presidential election cycles. wow, some alliteration there. It was hotly debated during the Democratic Party primary, if you guys remember, in 2019, 2020. So this would create a government issued insurance plan that is, again, an alternative in addition to private health insurance that anyone can sign up for, and that would compete with private insurers, which, as the theory goes, would bring down premiums for everyone, not just the people who have the health insurance. You just would have a much cheaper option in the market, and that, and then that would cause other, because of the theory of competition, that would cause other prices to drop. And like in Medicare for All, the government does not need to turn a profit, so they can keep costs relatively low compared to private insurance companies. The insurance would be subsidized on a sliding scale, becoming cheaper the lower your income is. The specifics of this plan, they can get really complex, and they can differ between proposals. So if you want to know, like, people who just had one, I think Kamala Harris had one. I don't remember if there were any more. Senator Warren might have had one. So critics on the right say that this is a slippery slope to socialized medicine, and that it would also require increased taxes. And critics on the left say that it does not address the fundamental problem with American healthcare, that healthcare is a human right and should be free to all at point of service. All right, and then the Colorado health insurance option, this is what someone was asking me about. So this is on the docket. It's on legislative docket for this year. It has two phases. Phase one would require health insurance companies to partner with other companies in the healthcare industry to bring premium costs down. So they would get together with hospitals and with pharmaceutical companies, and they would say, we need to bring down. So there's a number associated with it. They need to bring down premium costs 20% on like their standard plan in 2 years. So they would get together with those other stakeholders, and they would make a plan to try and bring down costs 20%. So it's not just that the insurance companies are being forced to bring down costs no matter what it's doing to their profit margin. They're saying, okay, well, we need to work with hospitals, to work with farms, so that we're getting charged less as well. If they are unable to meet the 20% requirement, we go to phase two. And phase two creates a quasi-governmental nonprofit kind of thing, complicated, but that it will offer an insurance plan or a public option that's 20% cheaper than what the private insurance companies are charging per county. So they would county by county. The plan has no proposed tax hikes, and there's no mandate to purchase any insurance, no individual mandate or anything. So I know that there's some, okay, so like I'm talking as me, I'm not the union. There's some issues that people are raising about whether or not it's going to like cause healthcare costs to be, healthcare, it's going to require a lot of cost cutting from the provider side, which would mean like layoffs or wage cuts. And like my view on this is that as a union, unions should not be in the business of preventing good social change if it marginally hurts their industry. Again, this is not the view of this is not the view from the union. It's not like an official stance at all, but that's how I think about these problems. I like this plan. It obviously has a lot of issues. It's not perfect. It's not like the full Medicare for all. But I think that it is a step in the right direction. I am really bad at reading like that dense legislative text, and I'm also really bad at knowing what like how something is going to like have an impact downstream. So if anyone has any other things if anyone knows any more about this bill that like I don't and wants to talk about it, that'd be great. Because I mean, this is obviously getting pushback from the industry. But I mean, I don't know. Yeah. my view is that if this is going to create a cheaper health insurance plans and is going to get more people insured, that's good. And again, like if they do it by like the pharmaceutical companies have to lose a little profit, the health insurance companies have to lose a little profit, and as we know, UC Health has a massive profit margin. They can definitely stand to lose a little bit to help the social good, to like provide everyone with or to provide more community stuff. Okay. All right. So does anyone have any thing they want to add about the Colorado health insurance option? A couple people here who know some stuff. All right. Okay. I'll move on. Oh. I have no idea. She's been sending a lot of emails. Oh, I'm assuming, Leah, that you're I guess I shouldn't assume. Are you at UC Health? Leah, are you at UC Health? Yeah. So she's been sending out a lot of emails that saying some of them are, like specifically union stuff, and it's just like some of them are stretching the truth, some of it is, and then some of it is like outright lies. And they are threatening to. They're in the business of threatening stuff right now. So I think that they just have a very clear incentive for this to not pass, because their revenues would go down. So I think that's really all I know about whether or not we're going to lose our jobs. I can't imagine that with the amount of like we already are short, and if they start firing people because like their profit margin goes from 800 billion to 400 billion, like that is ridiculous. I'm like, that's what this union is for, right? So we can push back against them for that. Yeah, I mean it's a 20% cut on the average plan. So like some of them are going to be less than that, some are going to be more than that. It's we're not forcing them to provide care for free. That's ridiculous. I actually didn't see that email, but all right. So I'm pretty much coming to a close here, but something that I want you to all take away from this, that like there is no place that I can point to that says this is where we need to go, or like this is a system that we need to implement. Every system has its major flaws, which is one of the reasons why this is such an intractable problem. Yes, the NHS in Britain is free at point of service, but they have this government board called NICE, literally called NICE. And they like really worked at it. They really worked at it, that acronym. It stands for the National Institute for Care of Health Excellence or something. So like there's more letters than that. They just wanted to show they had a lot of PR issues. So they just wanted to be like, look, we're nice. But so this board chooses what gets paid for. I mean, they don't make real-time decisions about like, okay, like is John Smith going to get his cat today? Like, oh, like let me look at his result. Like they don't do that, but they say this drug provides good benefits, and this is what we're going to pay for it. Or like we don't think that this drug is good enough. Like they're kind of like the FDA, but they also set prices. So so France has been named the best healthcare system in the world, but their providers make so much less than providers do here. I mean, they all make probably between 150 and 250 grand a year. Literally, like there aren't the millionaires. Like when I'm talking about providers, I'm talking about doctors. There aren't the millionaire optometrists in Florida who are scamming Medicare. So like that, you know, like that's good from a cost standpoint, but it's also one of the reasons why we have such good medical innovation. We don't have good health outcomes, but we have a lot of medical innovation in America is because being a sorry, there's banging. Being a doctor is so lucrative, so we get some of the smartest people to do it. Canada has a single payer system, but you have to wait for non-emergent procedures and appointments. This is their health rationing principle, is our wait times. In the NHS, it's that board. In America, it's costs. And like, so something that I want to talk about real quick, that the health rationing thing, I think, is something that we don't talk about enough in the context of Medicare for all. Medicare for all, the way that I think that like Bernie's proposal is for everything is free at point of service, but we can't really have that, and with no other interventions. Like, we can't just like, oh, I decide like my toe hurts a little bit. Well, like, why not just go to the doctor? Like, who cares? I can just walk into a doctor's office or walk into the emergency department, and just everything is free. That's not really, that's not like, that's going to cause healthcare costs to go up, not down. But anyway, but yeah, so like, I wish there was a country I could point to and say, like, we just need to be like this, but trade-offs need to be made in every system. So America has chosen as our trade-off choice and maximalism for high costs, high rates of uninsured, and like shocking amount of medical bankruptcies. I personally have a strong moral objection to these trade-offs. I wish we had a different set, but like, people made this system for a reason. I mean, they didn't. It was more like a status quo bias for a while, but and that's it. Whoops. So hold on. This like clicked my. Okay, there we go. So this is I can recommend some more stuff here. Yeah, maybe. Yeah, maybe. Peter, I don't know. So this first book is an incredible book about healthcare costs, and it kind of gets into stuff like how you can personally like increase your the price transparency around your own healthcare. Healing of America it analyzes each country's health system. It's actually by a guy who used to write the Denver Post. Medicare killed Jim Crow. I wanted to drop this into the chat. This is an article that is an excerpt from a book I am actually still reading, called When Markets Fail, I think, or Why Markets Fail. But it's an article about how the federal government used it's like how they use the power of the purse to desegregate hospitals, and just like the incredible work that like this guy Mike Holloman did for the healthcare arm of the civil rights fight. It was just like, it's so good. Sarah Cliff is she's like the best journalist in the world. She's for the Times now, the New York Times now, and she used to write for Vox. She did this story, this project where she was collecting people's health insurance bills, or sorry, their hospital bills, and then she would contact the hospital and be like, well, like, what does this mean? And then the hospital just like, oh, yeah, that doesn't mean anything. They're actually good. Like, they actually don't owe us anything. So like, Sarah Cliff herself has gotten like hundreds of thousands of dollars of medical debt just like forgiven, because just like all she does is just like contact the hospital, because she has the resources, the time, the knowledge of what to say, and like most people just don't have that. And then this is a podcast, the Crooked Media kind of thing with the Pod America guys, but it dives into healthcare. It's like a weekly podcast. I'm talking about coronavirus now, but Abdullah Al-Sayed is he ran for the governorship of Michigan in like 2018, but he's a doctor. And then I have some other podcasts if anyone wants. But are there any questions for me? right. Well, I hope you guys enjoyed this, and this could be the first of a lot of other things. I have a lot of ideas and opinions about healthcare policy and stuff like that. So I mean, just about policy in general. But if you guys have any questions you guys want to ask me, you can email me. This is my email, and I'm happy to answer anything. And like, I don't know. Oh wait, you know what? I want. Yeah. So yeah. Great. Thanks, guys.
And thanks everybody for coming. This is the first ever Denver Health Workers United Teach Yourself crossover with University Health Workers United. We're so excited to have this happening.
Yeah.
Denver Health Workers United Teach Yourself happens every month. We have free Zoom lectures open for everybody if you're in our union or not. Next month, we have a social worker presenting to us about recidivism in Denver, which is going to be super cool. After that, pre-hospital airway control and also some like fun pharmacodynamics for the non-pharmacist education coming up. But yeah, thanks everyone for coming. And
thanks, guys.
Seeing you all here.